This is an impossible column unless you looked at those pedigree symbols a little bit. So did we look at the pedigree symbols just a little bit? No. Yesterday during the lecture, right? Okay. Uh-oh. Did we finish attendance or not? We were just talking about that. We don't do those. All right. Let's check out the clickers. Oh.
I know the answer. I just don't have my clicker.
No, saying it out loud. That's called cheating. No Googling it. No Googling it. You were educated on this yesterday. You were told the year. You were told. How many people heard the year yesterday? How many people remembered what they heard yesterday? Yeah, that's about right. Okay. About half of who heard it. That's right.
How many knew it before they heard it?
It's got to be working here. Okay. Where is it?
Everybody. They'll walk up. That still works.
This time, don't pull in here, just Manchester pull. I don't know what happened. I don't know if we're disconnected. Oh, let me see if I can get it. Oh, repull. Anybody know how you repull again? I don't either.
You call Florida? That was actually the best one.
Would you report to Miss Dexter for me, please?
You were just on it.
You just passed it.
Oh, okay. You're testing. Thank you.
Right there. Right there. Right there. Right there. Right there.
Okay. Nobody in here punch. Not yet. Okay, so Manchester's online. Stop punching in Manchester. You're wrong if you haven't punched already correctly. Now punch in here. Where's your phone for? Do you guys know how to take your finger and press? Yes? Hi, I'm trying to do a DE polling. Everybody want to listen in on this? And I can get the remote classroom, but I can't get the near classroom. I'm calling from what room am I calling from? PA, yeah. It's 100. Yep. We're to Manchester 30, whatever it is, PA room. But I can get the distant room. I can't get the near room for the polling. I can get the distant room polling, but I can't get the near room polling. Okay. Bye. Okay. We don't have any technical issues, do we? Yes, 44, which is why it was really hard for the offspring born in 46 to 45, sorry. No, he 40 to mate with the guy who died in 44 when there was no sperm banking. Okay. We're going to go back to Mendelian inheritance. Everybody remember autosomal X-linked dominant recessives, right? Same slide as before. You have this one down? Okay. This is autosomal dominant pedigree pattern. Huntington disease, achondroplasia, polycystic kidney disease are all dominant, okay? So what are you going to see? Are you going to see somebody in every generation? Probably. What conditions would lead you to the thought that you might not see somebody in every generation? And a dominant trait. Say again? Late. It could be late, but what would the term be for that? You get older and then it shows. Not presentation, but penetration. Okay, so if you don't penetrate until, or only a certain percentage actually penetrate the trait, then you could skip generations, right? What's another way that you could see skip generations in a dominant trait? Any guesses? Would you like to express yourself on this issue at all? Think about it, make an expression, kind of, express yourself. Yes, that's right. So if you don't have full penetrance and you don't have full expression, then you might miss it. And remember, mild traits and some other things may not show through, not because they're not showing through, because we're too dumb to recognize them. So we may see it, but we don't recognize that's really an abnormality. Or it's so mild we don't care. So it may still be there as a mild bit of expression, and may be missed as part of the pedigree in the analysis. So knew Uncle Ernie really was as bad as he was in passing on the trait. Some of you remember the Who, don't you? So dominant conditions are expressed with just one copy of the mutant allele of the two alleles available, or multiple alleles even. Affected males and females are probably equal in how often they have it. And affected individuals with a normal copy and one with a mutant copy have a 50% chance of passing on the trait, assuming full penetrance and full expression. About half the kids will be involved. Now, everybody remember their statistics? No, we'll do that later, I guess, huh? You have 6 kids. Well, let's make it easier. 4 kids. What are the chances that every one of them would have the trait?
50%.
Well, first off, it depends on the genotype.
You have 4 kids. Every one of those kids has the dominant trait. What is the likelihood of that happening? 1/16, 1/2 times 1/2, 1/2 to the 4th, right? So you can kind of see how it sort of is unlikely. So around half, but it could be that you have a dominant trait and they never pass it on. 1/16 would not have the trait, okay? So it's not 100% absolute. And then you throw in penetrance and expression, and forget that. That's where it gets really messy. And that's why genetics was never something I thought was great fun to do clinically. Autosomal recessive, what has to happen for the trait to show? You have to have both recessive traits, right? So these two are the affected ones. What do these things mean?
Carrier.
They're carriers. Now, is this really a pedigree that you would see from a clinical assessment? No, because all of these are going to look completely normal. You're going to have these two. These would be your probands most likely. And you have to go back and assume all these because these are normal phenotypes. Occasionally they can come through a little bit, but these people all look normal, so it would be open boxes all the way down except for these two. That's what you would map. Now you would go back and analyze it and figure out who your carriers were. Okay? So you have to have 2 copies of the mutant allele. Your carrier are going to look normal. Females and males, again, will be equally affected. When 2 carriers mate, each child has a 25% chance of being a homozygous wild type. Okay? Half a chance of being, this is wrong, and I don't know where that came from, heterozygous mutant. Chance of being, 25% homozygous mutant, 50% heterozygous. Okay? I was reversing those thought processes. So half of them will be carriers. A quarter will be affected, and a quarter don't have a chance of passing it on. Okay? Now we get into those X's again. So we got Duchenne's, hemophilia, we've got X-linked severe combined, otherwise known as SCID, and other congenital, there are a number of forms of congenital deafness. So the recessive linked traits are going to show up in only girls, right? No. Why? Right. Hopefully, the girl will have a normal to cover up the recessive trait, right? What happens if the girl gets 2 of the trait? She'll show it. Okay? But it's how much easier is it for a male with only 1 X to show it compared to a girl with 2 X's? Twice, 3, 4, I know, quite a bit more often. And let's say it's a lethal condition, how much more likely is it for a girl to show it than a male? Beaucoup. You knock off all your males. Okay, is what happens. So all X-linked recessive are fully evident in males, assuming this expression and penetrance thing. You only need 1 X. Women are rarely affected because they have the 2. No father to son transmission. Why? He only passes the Y. Father to daughter and mother to daughter and son transmission are possible. And then if a man is affected with an X-linked recessive condition, all his daughters will inherit 1 copy. You have to, right? You don't have nothing else to give. All right. Anybody know about Queen Victoria? You didn't realize medicine had so much history to it, did you? Anybody know what they think Mozart died of? Amadeus, Wolfgang, Wolfie, Mozart. These are really the interesting things, I think. They actually think he probably had rheumatic fever with valve damage and went congestive heart failure is what took him. So, anyway, this Queen Victoria, this is her pedigree. Okay? I want this memorized. On the exam, you will be asked, generation 4-5, name him. No. But here's Edward, Albert, and Victoria. We kind of wander off a little bit, but what you're seeing is these are the hemophiliac males. If you notice, no father passes anything along. Only the mothers pass it along. And once you start interbreeding, that's when you have a higher chance of it showing up, as well as any time with recessives. But this is the royal family. Anastasia, these are the folks who got knocked off, all assassinated and all. But here you're seeing the male pattern. And this generation was not a good generation, for instance. And then it disappeared once you got down to Philip and Elizabeth and Henry and William. Okay. Little consanguinity over here. We know about the royals. I don't see. Is there any other consanguinity there? Oh, wait. Oops. didn't know she married a cousin. Did you know that? Did you care? X-linked dominant. These are kind of unusual. I really was not aware there were as many of these. Some types of retinitis pigmentosa, chondroplasia punctata, hypophosphatemic rickets is another form. This one, the gene is on the X chromosome. There's no transmission from father to son. Again, why? Father doesn't give a son an X. He's very nice, only gives him a Y. Can be father to daughter. All the daughters of an affected male will have will be affected, dominant, since the father only has one X to give. Mothers who are affected, about 50-50 chance of passing it, right? And the disorder is shown with just one copy. You don't have to have both copies. So again, dominant. That's all that last line is saying. Now, who picked that up? I looked at this pedigree for a while and went, what? Can be transmitted from the father to a daughter. No transmission from father to son. Father, son. Somebody did a typo. That would have to be a daughter, or it would have to be an empty circle, right? So, when you look at the pedigrees, you're going to have to figure out. But this one took me a minute because I was having trouble with that little box there. Couldn't make sense of it. A couple of Fragile X is a condition that's an X-linked dominant. This is really quite common, and I'm afraid I've not diagnosed it as much as I'm supposed to. The frequency is really relatively high. Anybody go back to the beginning of their slides? It was like 1 in 600, 1 in 800? Anybody remember the... It's high, and I've certainly not diagnosed enough of these because they really are not startlingly different looking. They have very long faces, very prominent ears, flexible joints, large body size, very large forehead, and they're, how you put it, well hung. They have macroorchidism, or they're very large testes when you palpate. And it's sort of surprising when you see one of these kids how large their testes are. And that actually is one of the markers. It's a little hard to do prepubertal, very hard to pick up in females for some reason. I don't know why, but it's not there as well. There is a comparable, there is some suggestion that some females can show some of these traits. But the Fragile X really is a male condition. Rett syndrome, this is just, I'm sorry, this is from another slide. This also is X-linked in females. Males are lethal. So how many are going to be expressed? I believe the word would be 0. They're not going to penetrate. They're not going to make it through. These are kids who really look kind of normal. And then all of a sudden, several years old, kind of school age or preschool age, you'll start seeing this hand play thing. And and they start to regress and you can't touch them. You can't stop it. It's a really devastating illness. You have a very normal child. Now, tell me what would happen if she just got her MMR at 4 years of age. What caused this regression? This is often the confusion we're running into with vaccines. We give a lot of vaccines when kids are doing developmentally interesting things. And I'm sure Rhett's has been one of the ones people have used, held up as bad vaccine stuff. Y-linked. Wait a second. Chuck it all, right? Not necessarily. The Y can hold on to it. Basically, Y-linked would only be expressed in, thank you, very good, especially that you're reading. They always have an affected father. All sons of affected males are affected. That's almost easy, isn't it? Should it be that easy all the time? It's not. Oh boy. A family presents with this pedigree for Leigh syndrome, or Leigh, I think it's Leigh actually, syndrome. You suspect what form of inheritance? Autosomal dominant, autosomal recessive, mitochondrial DNA, X-linked, dom, recess, and Y-linked. Oh, I'm sorry. You guys can't punch yet, can you? That was a quick response. Well, do you mind if we punch and see how stupid they are, or do you want to? I'm sorry, Manchester, I didn't mean that.
Sure.
I think I'm in danger when I get back now. None of yours are working still? Okay. All right. Well, in fact, it's actually mitochondrial DNA. Okay. It looks X because all you're seeing is females to family, but look what's happening here. So dominant, that's okay. That would almost make sense there. But the rules of thumb for a mitochondrial DNA and inheritance. Now, mitochondria have some DNA. It's little tiny rings, not very much, but there are syndromes associated with it. And because the ovum doesn't get jettisoned entirely like the sperm does, you maintain some of that mitochondria. And that can be inherited. And that's what's behind that. So mitochondria located in the cytoplasm, they're involved in energy production. So guess what kind of defects you're going to see in mitochondrial inheritance? Let's read it off together. Heart, skeletal muscle, liver, actually too, believe it or not, kidney. Things that require a lot of energy are the ones that are often going to be the ones that are affected. So the syndromes tend to be weird syndromes. Things that I refer to a geneticist for because they're like too weird for me to remember. Okay. The transcription of the mitochondrial DNA, you get ribosomal RNA, then you get transfer, and the polypeptides are independent of the nuclear DNA. It's not related, so it's a whole different set of nuclear material, non-nuclear DNA. And inherited exclusively through the maternal line. That makes sense. Only the ovum contributes. Again, the mitochondrial DNA from the sperm tail is jettisoned, essentially. Yes? In that one? You expect me to know it? Okay. Basically, it's only going to go through the mother's line. So anytime you were to see a male, this male, for instance, has offspring, it will not be affected. This one has offspring, it will be affected. Okay? Here's a male, for instance, who's affected, has no effect. Here. Here's another male. The male can get it, but the male can't pass it. Okay? The mother can pass it to anybody, and probably will. Did everybody who procreate? That's male. Okay, so in this one, for instance, the mother gave it to every one of her offspring. So it's a maternal line, no paternal line. Everybody's affected. And the female line will keep it going, the male line will terminate it. Okay? Believe me, you get a raw one of these, I wouldn't give you this one as, maybe I will, since I've had to discuss it so much. But these are hard to interpret. This is getting fancy. Autosomal dominant, X-linked, stuff like that, you should have a good handle on. But this is a little better. These are references. These are not memory work for you. But, I mean, these are the type of conditions you'll see with mitochondrial disease. And most of them have renal tubule. This one is everything under the sun. Here's myopathy, renal tubule again. Here's Leigh syndrome. It's basal ganglion lucencies, maternal history of neurologic disease, or herself having Leigh syndrome, right? Makes sense. Infantile myopathy and lactate acidosis. When you can't convert energy, you can't take glucose and move it over, you generate lactic acid. Very common. So a lot of these kids will show you manifestations of lactic acidosis when they're stressed. Dystonias, again, they're all sort of a pattern of energy, strong energy producing or requiring organs. Dysfunction is what you're going to see. Very bizarre syndromes, okay? And if you diagnose one, you can come back and get A's in all the rest of your classes, okay? But these are really specialty stuff. Now, what is the most common form of inheritance, really, we probably know about? Multifactorial. Yes. In other words, everything under the sun. A little bit of this, a little bit of that probably influences what's expressed on it. This is Alzheimer's, heart disease, cancers, neural tube defects, schizophrenia, insulin-dependent diabetes, intelligence, height. A number of things are influenced by it. This is the BRCA1 gene, for instance. You'll have numerous genetic alterations. In other words, a lot of different forms that can be out there may predispose individuals to the same disease. That's the heterogeneity. So you can have all sorts of chromosomal patterns, but the environment makes it express similarly. That's a heterogeneity issue. Coronary heart disease, risk factors include, all of hypertension, diabetes, hyperlipidemias are risk factors for coronary artery disease. And each one of those has its own multifactorial effect. And gee whiz, it's a lot more complex than Mendelian inheritance, right? Yeah. These pedigrees are very interesting. So hallmarks of multifactorial inheritance. Most affected children have normal parents. How does that do for your pedigrees? Makes it difficult. Recurrence risk increases with a number of affected children in a family. If you have several kids that are affected, you're likely to have more. If you don't, you're not as likely to have. Recurrence risk increases with the severity of the defect. So the more severe the presentation, the more likely you're going to have it within a family, blossoming in other people. Consanguinity. I'm sorry, I grew up in Virginia. You can't say consanguinity any other way. Who grew up in Boston? Say consanguinity. Is that boring, guys? I mean, that just doesn't get you at all. It's consanguinity. But anyway, the risk of affected relative falls off very quickly with the degree of relationship. So there's a clustering within a group, but as you get further along in the family, that genetic change and probably environmental changes, who knows, will start to fall off the fact. Now this is one. Pyloric stenosis is a condition where the pylorus is hypertrophied and the kids barf. I think I showed you the film, the little guy barfing. If a girl had pyloric stenosis, her son would have a much higher rate of recurrence risk than her daughter, and would have a much higher rate than her brother's children, because it's much more common in males. So in males, it's there. In girls, it's unusual, making her children a higher risk for expressing it. Okay? Does that make sense? For the cases of multifactorial, the sex that is less likely to have it is more likely to pass it on if they have it, if they end up having it. Okay? So it's kind of a weird pattern that way. Is that really it? There's not another page there? There's only one hallmarks page. Wow, I thought there were two. Good, good. Do you guys want to let them to do this or not? Oh, don't bother. This one's garbage. Okay, these are examples of pedigree analysis. They really haven't come yet, have they? Give me your guesses. What do you think is happening? You guys, what's this mean? Dead. Okay, dead. Best guess? Autosomal dominant, I hear. Anybody want to go with another one? X-linked dominant. Why not? Okay. It's a 4-generation affected by lattice corneal dystrophy type 1. You all remember that, right? From your ophthalmology? No, okay. Autosomal dominant. Okay. Asterisks are actually the people who have underwent clinical examination. So, in fact, nobody over here, we don't know if they really truly have a full evaluation. So in some ways, you may be missing things because they never really got the full evaluation. Okay? That's going to complicate these analyses a little bit too. The only dominant one parent can do it too. All you have to have is the trait from either parent. Okay, and let's do the reverse. In an autosomal recessive, you have 2 carrier parents. What's the risk of a child expressing? 1/4. What's the chance of the child being normal? Huh? Yeah, 75, 3/4, right. Okay. Give me this one. Yes. It's going to be male. What's that? Yeah, you're right. You're absolutely right. Very good. Very good. Because this, you would have to get an X from this person. They're dead. Okay, now that's a whole other thing. The kid dies at 2 years old and the disease doesn't occur until 3 years old. You just missed a person to make an assessment of. That's why the hash marks are really important with that. But I'm sorry, this right here you're saying. Yeah, both of these should be affected. Because they would have to, wait, I'm not doing that right. No, I'm doing it backwards, that one. I was having trouble coming up with the exact reason. This is X, that's male. Both of those would have to be affected, yes? Any other example on this that we can go for? It's really a whole lot easier doing these when you have 8 kids per family. It's horrible for living, but it's a whole lot easier. Yes? If it was autosomal dominant? Yeah. Well, again, you don't know because they're dead entirely, and you may not know the answer. You would assume one of these would have had it. Yeah.
A question for the 4th generation, number 1.
Yeah.
She's not the patient.
Say again? Yes, this one should be. I think that's the one we decided should be, yeah. Okay. This one. Okay. Do you see it every generation? Is it only in one sex? Okay, automatically you're sort of going to what type? Kind of a recessive, because you're not seeing a good lineage. Again, these are assuming full penetrance, full expression, okay? We're not playing that other game right now, okay? So somewhere in here, this has got to be recessive. You got different male and female. Are you inheriting it? Here we don't know. Well, you know you inherited it probably from both if it's autosomal recessive. This one should have 50-50 chance of kids being involved. Bad luck. It's X-linked, but where's the, okay? So that's called bad luck at that point. Up here, one is affected. So you just assume 50-50, right? 2 recessives and a dominant recessive. you'd have 50-50. Only one was affected. That's kind of lucky. Okay, but it's probably recessive. Oh, that's how you'd read it, right? I forgot I did this to myself. Polydactyly, too many fingers. Autosomal dominant, but typically, in the absence of a new mutation, all affected children must have at least one affected parent. It shouldn't skip, right? Reduced penetrance. Doesn't that suck? Yeah, I'm showing it to you, but I'm not going to. But you can see, I can't read it. I don't know how to read it. Oh, I'm not the best pedigree reader, but you can see this gets really confusing when you start playing penetrant and expression, right? Now, a term that you want to know about, it's just a vocabulary term, but individuals with a trait in a dominant trait are not carriers. They're obligate heterozygotes. Why that matters, I don't know, but if you hear people talking about obligate heterozygotes, they're talking about dominant. If you're talking about a recessive trait, you're talking about a carrier. They're really the same constellation of genetics, but for some reason they like to make that distinction. Okay, albinism is inherited as an autosomal recessive, and it's a little more complicated than this. We'll get to that. Assuming the persons from the general population are not heterozygous, meaning that they don't have a little a, and what are the probable genotypes of all the persons whose genotypes are known in this thing? I'm not going to make you work through it entirely. What is the genotypes of these? Okay, let's go with little a. Okay? Do you know what the genotypes of these are?
No.
Not really. What are the genotypes of these?
Area.
What's this one?
Area.
They should both be heterozygotes. I think I actually added a couple more. You would assume these guys would have to be heterozygotes because we have declared that the people in the general population were not heterozygotes. That was the declaration. So all of these would have to continue to be heterozygotes in order to generate something down here. Okay? A homozygote child, eventually. Albinism. It's cutaneous albinism. It's an autosomal recessive trait, meaning that you have two parents affected. What will happen to all the kids? They'll all be affected? %100% affected? You sure? You'd hope so, but it's not as easy as that. Okay? It takes 5 functioning genes in order to generate your pigment. Okay? And there can be mutations at all 5 of these locations for you to generate melanin. As long as you're heterozygote and you have some function, then you make it and you get your melanin. If I have 2 parents here who are not affected in the same gene, they still make a normal kid because the other parent contributes the normal gene. They have to be defective in the same gene for that to happen. Isn't this hateful? How dare them? That's right. So, in other words, you have 2 parents, both have albinism copies of OCA1, and also here, all they can generate are kids with OCA1 defect, right? However, if I have a family where mama is OCA1 and father is OCA2, they can have normal pigment. Because they're now heterozygote for OCA1 and OCA2, they get the melanin production going and they can get started. There are some that will show different levels of expression, but for the most part, it's not as simple. This is the problem with Mendelian inheritance in humans is we aren't as clean. We kind of didn't follow the rules. We're not little peas. And besides that, we're not faking the data. So again, this is the same type of concept. This is the normal phenotype. The tyrosine is the same sort of thing. Mutation is here. Mutation is here. These two couple up. And here, you're not going to see. You're going to see partial function of both. So you might have some degree of pigment change, but you're not going to be fully albino. Okay? I saw a father 2 nights ago who was albino. He was from Tanzania. You see it often enough. You know, his kid was fully pigmented. No issue. You'll see albinism more than you think. And it does have health issues, significant health issues, melanin, skin cancers. Often they have ocular issues as well. He had a wonderful nystagmus the whole time you're talking to him. Any ideas? Who's involved? Males and females? Yeah, both. Okay, that doesn't help you entirely. Does it skip generations?
No.
Not really. Where do you inherit it from?
Father, ex.
How many people vote mom?
Either.
How many people vote dad? How many people vote Uncle Ernie? How many people vote the guy at the bar 10 months ago? No. I think the cockhold rate in the United States, last I heard, was about 10%. So when you're doing pedigree analysis, you get a 10% fudge factor already built in, because the genetic material isn't known. So, yeah, that gets messy. So this kind of looks like the only people that pass it on are who? This guy didn't pass anything, luckily. He was kind of a retard anyway. So it looks like anytime a male is involved, it doesn't go anywhere, right? Here, here, oh, wait, yeah, here, here. When the mother's involved, it tends to be kind of 50-ish, 50-ish.
First generation.
Right? What's that?
But it's
About
still
1-1.
so second generation.
Oh, the male, yeah, at the top. I wonder, oh, that's going to be cool. This is actually dominant, and let's see if we have a problem. Trait is never passed from father to son. Okay, that's true here. He only passed it to the girls, and 100% of the girls got it. All daughters are affected. All sons of an affected male and normal female are normal. We saw that. He knew it was X-linked because it really was tied to one gender, for the most part, passing it on. It just seemed to... Matings of affected females and normal males produce half sons and half daughters who are affected. 50-50 pass on them. Well, I don't really care about you, do I? Males are usually more severely affected than females. In case many of these are lethal. Females are more likely to be affected than males, even if the disease is not lethal. They have more of that X stuff around. Okay, what does this mean? Typically stillbirth. Stillbirth or fetal abortion, whatever. And what gender would you almost guess all of these probably are? Well, there are two genders, but which of those two genders do we think would be more likely to show up here? Notice they haven't designated gender in these, probably. These may not have gender assigned. I don't know. I don't know. Now I have to wonder. I don't think they actually give you. They should give you if they're old enough, but some concepti you can't tell. So by the time they abort. So this is somebody who's had a very clear problem of something going on that's aborting an awful lot of babies. Okay, so this is lethal to probably males. The women, it's only passed through the women line according to this. He didn't do anything to the poor kids. And it looks like about half of the mothers are affected. Okay. So X-linked dominant. Okay. No affected males. It's lethal. They're dead. They're gone. You'll never see. I had a family that they had a condition of this.
So Dr. Frenberg,
Yes?
number 7 is the exception, right? Because,
Number 7?
yeah,
Because the mom is heterozygous for the X-linked dominant.
mom is not.
Dominant. She may have passed to recessive.
According to the concept.
It does seem that way. Let me see. Wait, 1, 2, 3. It depends on whether she's heterozygote or not. I think, doesn't it?
She's heterozygote for the X-linked trait.
Yeah. So she's a heterozygote, so she has a 50-50 chance of passing it to the boy and the girls, right?
Yes.
So you can have a normal son out of an X-linked dominant. Okay? But again, males are not at much luck of passing this one by as much as the girls are. Okay? What was your question?
I was just saying, so we can assume.
I would assume I would assume these are more likely to have been males. It could have been something else. There are no affected males, only affected females. Lethal. That makes it easy. Living females outnumber living males 2 to 1, just by the assortment of the dominant and recessive genes. Okay. And spontaneous abortions of male offspring is increased. Okay. Spontaneous abortion rate in the United States is about 1 in 6. And what did we say? I mean, was there chromosomal issues in a lot of pregnancies? Yeah. So you can imagine we probably are trying to avoid suffering. Who knows how that works exactly? We still don't have clickers, do we? Okay. I really want my clicker. Can we let Manchester blow this one for you guys? Okay, Manchester, show them up. You can talk. You can talk among yourselves. Oh, shoot, it came out. This was not supposed to come out. Well, the answer's right there. Never mind. Don't tell them that, though. Guys, don't tell them the answer's at the bottom. Okay, look at it. What do you like about the rhythm or don't like about the rate? Let's go with rate. Slow rate. Don't even have to count it off. Slow, right? What do we know about the rhythm? Kind of P waves look okay. QRSs match up with P waves. Not too bad. So what is it called? A sinus bradycardia. You're right. And axis? Thumbs up. Okay. Upright in F, upright in 1, right? Progression? Kind of goes from negative to positive, yeah, overall. But what transition maybe around it here somewhere? Not far off, right? Anything? Q waves? Probably just here. This one we have to ignore, right? Do we see any ST issues?
Yes.
Where? Not 1, 2, 3. V1 through V3. Okay? And that would be consistent with? You have ischemia going on in the anterior of the septal area, right? Darn. Can you guys applaud them? Please stand up and take a bow. Oh, don't give them out. They punch the right button. Give it to them. Stand up and take a bow. I'm watching. Now. Hey, I'm writing that one down. All right. Are we going to let them click or not? Legally, I'm not supposed to let them click. Because you're disconnected. That's the problem. But you can let them click. I'll let you guys vote on whether to let them click. If you don't want them to click, we won't let them click. You want them to click. Is that true? Any abstentions to that? Any refusals of that? Click away. Click away faster. Very quietly so they can't hear what we're talking about over here. What do you think about this one? Does it skip generations?
No.
Does it affect males and females equally? Can you get it from either parent? Is it relatively even in the number of offspring? Except for here. This is weird. Yeah. I don't know. This is taste blindness, believe it or not, which is kind of one of those great... What is the term when you put the wrong sensation to the... What's the name of that? Yeah. So it's going to be a recessive in this case, and I assume the reason you have to stay with recessive is this block right here. Oh, I hate it, don't you? They got it right, more than not. But this one would be, now if we chop this off, you would tend to have to think, this actually, I'm sorry, right here solves it. I'm sorry, I missed that one altogether. You have, it skipped a generation, legally, right there. Right? You all saw that in Manchester, right?
Yes.
Yeah, I thought you did. Okay. S-linked recessive, if the father's normal, he can't pass on a recessive trait. He can only pass on. He can't pass it on. Okay. Mother has two X's. X-linked. All the males have to be affected for a female. Yes?
Question. So, for the coming final, will you give us this kind of question? You know, for those carrier, you didn't show us the genotype. So just like the normal, normal person. So we have to guess.
Uh-huh. You're right. Do you think I'm showing you the easy ones?
No.
Thank you.
Easy ones on the exam.
Okay, X-linked, I have to go back and actually look at the sheet again to see all the rules to it. But generally, you're going to get it only on the from the mother's side. If it's lethal, for instance, it's got to only come from the mother's side. You won't get it from the father's side, a recessive, because the father can only have the normal. Well, if he's affected, then theoretically. But if he's normal, he can't offer anything to that. So the child can't be affected if it's a male. Right? So, I mean, it's just, you have to go down each sequential one. You'll read off X-linked recessive. What were the traits for that? Rather than dig that back up.
It's the women are good.
Not that far back. Shouldn't be. Okay. X-linked recessive. Not every male. Most males. A good portion of males. Did you hear that?
No.
Manchester? X-linked recessive trait do not manifest the normal copy. Okay? All X-linked recessive traits are fully evident in males. Only one X chromosome, no normal gene to compensate. Women are rarely affected by X-linked. They can only have it if two abnormal alleles exist. There is no father to son, but father to daughter, mother to daughter or son is possible. Okay? If a man is affected, all of his daughters will inherit one copy. Okay? What about this one? I would tend to think so too. Yeah. No skip generations, both sexes, comes from both sides. About equal odds of having it. Here it didn't show up, so it didn't show up in this line. Okay?
Dr. Brandon, question from Manchester.
Yes.
So for the third generation, the first two kids, if it's the autosome dominant, why don't they show the phenotype? They're supposed to be the patient too, right? Because the patient, mama carried two sick genes.
How many is she going to pass on?
Well.
Okay, this one. That was a wonderful thing, Q. That was good. I like that. I'll go with, I'm going to, yeah. Well. I think when you guys correct me from now on, well. I like that. What do you think? Not a lot of information here, is there? So what is the most critical thing you can say about it? It's male. It didn't show a female. Hard to say whether that means anything. But what's the most critical thing that you can see? There's a blank here. It's skip generation. So immediately, the first thing you should think, although you'll be wrong sometimes, is recessive, right? It's a recessive pattern. I hopefully. So X-linked recessive. This is not a big enough pedigree for me to be able to say that as conclusively as I'd like to. But you have only males, so that does lean you in that X-linked pattern a little bit. Multifactorial, you don't figure it out. You don't figure it out on the pedigree. You take the pedigree just to know how concentrated the effect is in the family. You can't. It won't be an inheritance pattern that you can interpret in any shape or form usefully, I don't think. Okay? This one's easy because they gave it to you. Yell it out. Yeah, they got the hash marks. You see the hash marks. Think trait, carrier. But I don't know how they're going to actually hit it. Yeah. So anytime there's hash marks, it's easy. The problem is in real analysis of the population, you don't see those little hash marks. If people will come up and go, they just don't have it. Okay. And then this one, you saw this pedigree before. Very good, guys. And this is the BRCA. Oh, this is the BRCA gene again. This one. You don't know, but the best guess is there's nobody around. You got this one kid. Out of the blue comes some other recessive gene, and they meet up and they make a singleton out of there. So very often in some recessive traits, you're only going to see a very few within a large pedigree as well. Phenotype on this one, it's passed from mother to offspring, from father to offspring, passed from mother to daughters only, uniform with minimal variability, passed only from females to aunts, but not uncles. So what is it? Mother to offspring, we're hearing. And we all agree. Okay. We're done with the hard stuff. This is the really harder stuff. No, it's not. How much time do we have left? Okay. Can we finish and then not worry about a break? Are we okay? Okay. Well, I didn't hear that no. Sorry. Let's just finish because it never get done. Indications. Why would you want to do genetic counseling? Why would you send somebody for genetic counseling? Advanced maternal age, over the age of 35, and paternal age over 50. They often recommend that you go off and get your genes checked. You're not always going to pick it up because you aren't checking every sperm. Consanguinity. Previous history of a child with birth defects or genetic disorder. You know that you're looking to see if that's going to recur. Personal and family history suggestive of genetic disorder, that's a little more obtuse. High-risk ethnic groups, known carriers. So if you're in a group, a family, a cluster, a population that has a very high inheritance pattern of something you might not want to see, genetic counseling is there. Or if you are not thinking of terminating, which a lot of people don't, and that's fine, you're aware of it so that you make plans, okay? So counseling is not just to terminate. Counseling is to let you know what's likely to show up in your lap. Documented genetic alteration in a family member or ultrasound or prenatal testing suggesting a disorder. This is the approach. It's pretty much what I just talked about, but it's one of those nice little algorithm things. But patient with a familial disorder, you do a pedigree analysis. You ever seen those before? Have you seen pedigree analysis before?
Yeah, we just thought.
Thank you. Yes, you have. You do linkage analysis, and a candidate gene is known. Then you go and you actually do specific analysis. If you don't know the candidate gene, you try to link it up to a marker to see if you can do it. It's all there, but basically it's an approach to decide how you go about picking it up. Now, indications for cytogenetic analysis, you've gone off and seen the counselor. They're going to decide whether they should spend the money, and it's a lot of money, to do testing on you. Okay, so grossly retarded physically or mentally at any age, especially with associated anomalies. What is one condition, for instance, that they often recommend genetic or cytogenetic analysis? Guy's kind of tall, long face, big ears. Fragile X. And that often, if you have a retarded male, they often say, well, we probably should consider doing a Fragile X with it. Ambiguous genitalia. Girls who have primary amenorrhea, well past the normal age, What would think about one of those? Turners with streak ovaries. Delayed pubertal development in a boy. Hypogenital appearance. What would you think about? Klinefelters would be one. Males with learning or behavioral disorders who are taller than expected. Fragile X-ish. Some other ones, yeah. Malignant, premalignant diseases. We do inherit some of those. Parents of a child with a chromosome translocation. So you know that somehow or other the child got an unusual complement of chromosome. You look at the parents. Parents of a patient with suspected chromosomal syndrome with other children in the family with a similar appearance. Multiple spontaneous abortions. Remember the lethal X-linked? That's one of the cases, but also a lot of other conditions will cause recurring abortions. So if you've had, there used to be a magic number of 3, I don't know if that's changed, but around 3, 4 abortions, you start to begin wonder if you have a Jacksonian translocation, that you're fine, you look fine, but your children are getting an uneven balance. You know, couples, infertile couples, really kind of the same issue. They may be having abortions without even knowing it. And then if you have prenatal issues that show up, so you have advanced maternal age, one parent is a carrier, previous children with a chromosomal abnormality, very severe intrauterine growth delay, disorders, biochemical disorders, neural tube defects, and trisomy can be reasons that you'd look at it in prenatal. The women who their first pregnancy is after the age of 35 are called elderly primips. Some friends of mine have taken canes into their first visit with the OB. You know, but you're elderly once you get to 35. Well, all of a sudden your trisomy rate, you saw it, starts creeping up quite a bit. And all. There are 2 ways you do genetic testing, analysis, cytoanalysis. There's the fluorescent in situ hybridization, FISH is the abbreviation. These are probes of single base mutations, is what they're mostly aimed at, although they use them as markers as well. Much faster, no cell culture involved, not as expensive. The karyotype, this is all we had when I trained, are those nice little banded chromosomes. They stack in a row. You can see little bands on them. Not very specific, very labor intensive, very slow, requires a cell culture. And it's really only available for visible defects you can see in the chromosome. So you can imagine with that many base pairs, not all of it's visible. This is the old karyotype. They're so cute. But they're banded. You know, all of a sudden you see that band is missing here. Okay, you got an idea something's on. You see something's chopped off here. Okay, missed its acro. You know, the end is gone. FISH is used to help detect DNA sequence. This is actually looking at the base pair sequence, or the base pair sequence, looking for excessive or deletions as a rule. It uses a fluorescent labeled DNA segment. So basically, each probe is specific to a certain sequence, and it will only bind to that sequence. So here's your probe. You can do it where you have the fluorescent attached, or you add the fluorescent attached, or add the fluorescence later. Some are a little more sensitive than others. You take this little probe, you go out and find a nice little piece of DNA. It finds it, matches up with it, sticks to it. Then you can make it fluoresce, either directly or add the fluorescence. And that area will light up. So you're actually looking at a specific DNA sequence when you do that. And you get pretty pictures. This one is a FISH. That's a normal cell. Now, the signals they have are chromosomes 13 and 21. And so they have 2 of each. That looks pretty. Oops, 21. The red marker is a 21. This is trisomy 21. So it's just a small portion of the 21 chromosome that they're fluorescing to. But that's how you're picturing that. This one, at the telomere, the end of the chromosome, short arm and long arm of chromosome 8. And what you'll see here This is a trisomy 8 because you've got short arm, long arm for 8 matching up multiple times. Okay. Normally, you'd only see those signals twice. And again, these are deletions, velocardiofacial. There's a specific locus they know that's involved in that syndrome. And if the probe can't find it, then you know that deletion is gone. This would be the normal one. That specific locus is missing in this one. Okay? So these are they're pretty too, but these are incredibly detailed in how specific they can get down to base pairs. Compared to the old chromosome analysis, very different. And then you can have really cool pictures. The whole family. Here we have little bits of 10 and 2 mixed up. They took pieces off of each other. I think we have a 6 and a 16, a little yellow in their pink, and pink in their yellow. So, I mean, you can be very detailed in what patterns you're going to see show up. These are some cases of microdeletions. Again, these are more for your interest and reference. Then you have to know them all, really. But I'm Prader-Willi, Beckman-Wiedemann. These are all things that you will see. Angelman syndrome. Miller-Diker, I've seen that enough times. Charcot-Marie-Tooth, which is the distal progressive neuropathy. Velocardiofacial, which is DeGeorge syndrome. They don't have their normal thymus. Thyroid, they're missing some defects in the midline. Third and fourth brachial arches don't develop normally. Okay? Mass genetic screening, I just want to kind of go over why we do what we do with some of this. These are tests that have to have a high enough sensitivity and specificity to be cost effective. If they're not sensitive, they're garbage. If they're not specific, then you have to chase up the results so much that it's way too labor intensive. So the test has to be relatively good. It has to be sensitive, it has to be specific to the disorder. The disorder has to be somewhat prevalent. It has to be out there. If it's a rare, the money isn't worth testing everybody. And it has to have some sort of serious consequence. Now, we have a lot of congressmen who have a grandchild that has this one condition, and they're trying to push federal law to say, do the test for this one condition because of the grandchild. Well, the grandchild's condition, no treatment affects it. You can't make it better. It's rare as hen's teeth, but they have a personal interest. And those are where we're seeing a number of fights going on about prenatal screening or early neonatal screening because of special interest, but it's got to be frequent enough, and you've got to be able to do something about it. If you can't do anything about it, why screen it in everybody? It's a cost issue you have to deal with. And you can't discriminate. You can't be doing undue discrimination. You can only do it for Irish ancestry. You know, that's going to be a little icky as far as it goes. So, for instance, Tay-Sachs disease, really rare now because they've screened it out so far that it's really not cost effective to do as a regular screening. Sickle cell, the problem with sickle cell disease, and we do screen it now, is that insurance companies immediately tag you. Now you're discriminated against. You will have to pay through the nose when you get tested positive. Okay. So requirements for an effective population screening in a new inborn errors. Disease should be clinically severe, potentially severe. Natural history is understood. We understand the disease enough to do something about it. The effective treatment should be generally available and dependent on early diagnosis. Disease incidence should be high enough to warrant screening. The screening test should, again, have specificity and sensitivity. Screening tests should be available to the entire population at risk, not just your friends. Okay? An automatic, a very good system of follow-up. So the ones that you find positive don't just sort of get lost. You will go find them. And I'll tell you, the state programs will chase us down to chase down patients unbelievably fast. They're very effective at it. And you have to be cost-benefit. It has to be somewhere in a positive realm. These are some of the conditions that you'll see that we're screening against. I'm not going to. This is actually what we screen in New England. New Hampshire pretty much has the same as Mass. Fetal ketonuria is one of the very common ones, but with cystic fibrosis, sickle cell anemia, C as well. Okay, and these are direct screenings. They have some really neat names like maple syrup urine disease. Smells like maple syrup. These are sort of 30 disorders that they may see something that they continue the screening for. So, I mean, this is what's being screened for. They're really kind of rare conditions, but they're often enough that they pick up a kid. And if they induce a change in the diet, such as phenylketonuria, without it, you're retarded, IQ of 30, hyperactivity, seizures, light complexion, blonde. It's an effect on tyrosine metabolism. So your melanin is affected even in this. But if you change the diet in the first month, that's the best result you get. You get the part of the diet that's causing the toxic metabolites. Phenylalanine deficient diets keep the level low, and children develop normally for the most part. Women who are carriers have to be concerned a little bit, or who have it, about their diet, because that phenylalanine issue in the fetus can also affect. So they're also supposed to be on modified diets as well. What time are we at? Genetic alterations in cell regulatory systems. Carcinogenesis. This is a cell alteration that leads to different cancers. It's usually one mutant allele in a cancer-causing gene. Likelihood of that cancer develop depends on that allele plus other genes plus the environment. So it's not just the one gene that affects it. Environmental issues really do impact your tendencies with it. If the mutations occur in the germline, then you pass it on, right? However, luckily, most cancers are really somatic cell line disruptions is what will be seen. First-degree relative can be very helpful in picking out your risk. That's why people who have family history of polyps are more likely to get GI screening, right? They're at higher risk of a GI polyp or carcinoma developing. Cancer genes that are used, they're tumor suppressor genes. They inhibit cell proliferation. Tumor suppressor gene disease usually has a recessive pattern associated with it. Oncogenes, these ones activate cellular proliferation. These tend to have more dominant properties when you see them. And they just turn on the cells to continue. And then there are DNA repair genes. These are the ones where they kind of don't fix the damage that occurs, ongoing damage all the time to your DNA, and you aren't fixing that damage. So those cells start to take over the abnormal cells. And this is sort of a whole bunch of those diseases, family polyposis, breast ovarian cancer, melanomas. We do see tens. There are genetic, but it's not 100%. Not every relative is going to have it. And it's a bunch of those for you. As you can see, some of the genetics of a number of, type B lymphoma, we really do know a lot about the genetics now. And part of the reason we know the genetics involved is because of the genomic studies that went on. Now, there are some gene therapies for cancers. You get a vector, an adenovirus, there are a number of different viruses they're using. They take a transgene, the gene you want to put in there, and you take a target cell, you figure out where the target cell is, pop the transgene into the vector, go after the target cell, and you see if it implants. And if you can get it into the cell line, you may be able to reverse some of the effects of the cancer gene. You may rid the cancer is hopefully what will happen. So transduction is when the donated DNA enters the target cell. It expresses in the transgene. You can do it in vivo, you can do it ex vivo, where you remove it, put it in, then put it back, is what they're doing. These are the types of diseases they've been doing it in. Cancer is where they've really been working. They've also worked a little bit on cardiovascular and infectious. But for the most part, they're working on cancer with this. There are some other examples of SCID, which we talked about, the severe combined. This was the first, this was sort of the baby of the project. And they've had 20 kids who were treated where they put in a transgene. 5 did develop leukemic-like disorder. 1 died. 13 are alive and free of complications at 10 years. That would be unthinkable in their normal state. That's a phenomenally. They did another pattern where they did an X-linked skid again, and they were able to do some gene therapy. They have 10 children involved, and they've done reasonably well just for their therapy. And this can become worse over time because of resistance to the drug. They're $200,000, $300,000 a year. Not a whole lot of insurance help with this. So this is essentially a curative process when they can induct the gene. So you can put in suicide genes. They kind of tell the cell to die. You can put in suppressor genes that sort of suppress the tumor. Oncolytic genes. These will actually make it viral genes that abolish their ability to replicate. Chemoprotections, in other words, you put in a gene that protects the normal cells from the toxicities of chemotherapy. You can modulate, in other words, affect the way that the cell responds to cytokines, chemokines. And you can also affect the angiogenesis. So you can turn around and actually stop the vessel production by modifying the statins of angiogenesis with this gene therapy. All of these are far more complicated than I can get into, or ever could probably even get into. So you can silence genes again, these are complications of doing this, however. You can shut down gene functions. Now all of a sudden you've shut somebody's vital function down. You can make complications where you put in a gene that was more dangerous than the one you were trying to get rid of. You can have an effect on the phenotype that you weren't anticipating. Same thing with immune pattern. You can pass it horizontally. Remember, a lot of the vectors are infectious agents. So you may be able to spread the transduction to people around you. And if it gets into the germline, you can pass it vertically. So these are potential problems with the therapy as well. There's the Human Genome Project. Started in 90, completed in 2003. 20 to 25,000 genes. That's how we know the number. And what this has done is this has not only helped us to understand the biology, but we can actually subunit. We can do this fish-type stuff that didn't exist before. We can do this in organisms and make them replicate, make drugs for us. We can induct a gene into there. And that's where insulin comes from now. We used to get it out of cows and pigs when I trained. Where E. coli is doing it for us now. A lot less immunology. I think more or less those are the main points about that. GINA, the Genetic Information Non-Discrimination Act, is important for you to understand. This came about in 2009 because we knew too much about your innards. It prohibits health insurers and employers from using your genetic information against you. Like, totally? Not really. They can't change your premiums. They can't prejudice against you to do that. They're not supposed to affect hiring, firing, job promotions based on your genetics. Well, that's only for employers for over 15 workers. It doesn't cover your life and long-term care. It's only for your health care. So there's a lot of discrimination going on when you get this done. There are a couple of websites I think you should have fun looking at. 23andMe. You can go out and find out what your genetic component is. You can have an analysis. Really cool. Now you will know your predicted response to drugs from blood thinners to coffee. You can find your cousins. All right? You might find up to 107. Right? That would only be first through fourth cousins for people of European ancestry, so forget it if you're not that. It can tell you that you have a risk as low as 8% or as high as 52% of getting diabetes. Is that helpful to you? For a few $100s? Well, a few thousand. I think it's, I don't remember. This is in the 1,000 range, I think. Is it less than 100 now? Okay. 40 plus inheritable conditions. Do we have a few more than that? Yeah. 9 out of 10 do not have these risk genes. 1 out of 10 would pass it on. There's this place called Microsort, and it went out of business a year ago when I looked at it, and now it's back in business. What it originally came out to be was they filtered out those nasty sperm with 2 X's and only took the top of the filtrate so that you could be sure you passed on a boy. It was gender. It's gender selection is what it is. And the euphemisms they use for gender selection are pretty fascinating with it. But I mean, this is, now they do X sort and Y sort. But originally, really, was just Y sort. But you know, these are the ones that have too many X's. These are ones who have good ones. But you notice a few bad ones filter in there every once in a while. Oh, sorry. What are the requirements? Have at least 1 child. They don't want to be responsible for total disaster. You're underrepresented gender in the family, whatever that means. You have to be negative for HIV because they can't clean the material enough. Remember, these things are going to be given back to you. You know, for HIV, hepatitis B, and C, they can't cleanse their machines, I guess, is the reason. You have to deal with X-linked concerns. If you're a known carrier, they don't want to really deal with you. You have to be negative. So these are the ones that will get you kicked off. They have to have those done before they'll even take your material. So it's about 91% purity, whatever that means, for girls and 74% for boys. So you got a 1 out of 4 chance after spending. This is 2012. Total cost is about 300 plus 3,000 plus 290 plus 36 plus anywhere 500 to 1,500 plus 1,000. Just to get your boy. Well, hopefully get your boy. No guarantees, by the way. Okay, real quick. These are, let me give you the answers on these. This one's autosomal dominant. This one's Microsort provided info for only culling out sperm with 2 X's. This is originally. What are they trying to do? Or they're trying to reduce the chances of matriarchal lineage continuity. Right? All one of you agree. Okay, Hardy-Weinberg. If the presence of an autosomal recessive is 1 in 100, what percent of the population would have only the normal allele? Think about it. Somebody yell it out. 4. Why 4? Why 99%? Thank you, 100 minus 1. Or you could go through the whole equation, right? Everybody get that? What? Oh, would only have, I'm sorry, only. So that would be 2 square, p squared, right? So it'd be 99 squared, right, sorry. Or 0.9 squared. Okay, you got 1 in 100. What percent would be carriers? What's the formula for it? 2pq, what's 2pq? 2 times 0.9 times 0.1, right? Anybody want to tell me what that is? 18. I think, isn't it? Yeah. Okay. And what percent would have a normal phenotype? You can say it again. 99. So it'd be 99. Okay. See, you guys really, it's not as far away as you think. Counseling. Which one of these is a waste of time? Although they changed it. I have to say they changed this a little bit, so this answer may not be correct. 3 is kind of the answer, but then they said over 50 males should get it, right? Yeah, that's sort of a change from my days of thinking. What's this? It's non-disjunction. What's the condition? Trisomy 21, Downs, right? Cystic fibrosis. Anybody know what the inheritance pattern is? Yeah. So which one do you want to say? And plus we have these nice little moons, right? And what do those little moons mean? Half moons mean? Not hemianopsia? Okay. Yes, they'd have a normal phenotype, right? Even though they're a carrier. And what is the story here? Yeah, it's whether you get the deletion. And there are some without the deletion, but the 15 deletion from your mother gives you a different signaling, silencing epigenetics than if you get it from the father. Okay.
Literally.